It's really my pleasure to introduce our speaker. So we are honored and privileged to have Dr. Anup Joseph Devasia come here today. Dr. Anup, as he likes to be called, completed his undergraduate medical training in internal medicine and did the internal medicine and hematology residencies in India, where he later became a very accomplished myeloma clinician, professor, and a very prolific researcher. I think you've taken part in 55 published studies. Wow, not many doctors have that many, and you're still a young gentleman, so very accomplished. And recently he was a member of the academic faculty of the Christian Medical College in Vellore, India. Did I pronounce that right? Yes. And he's now a clinical fellow with the myeloma group at Princess Margaret Cancer Center, where he's been since January 2022. So some of us here know Dr. Anup as a very active, knowledgeable, and caring member of the myeloma group at Princess Margaret. He has a very full schedule. Some people say that he's got wheels, the amount that he travels and sees patients and looks after some of the details, the many details of care. So it's so good of him to take the time today in his very busy schedule to prepare the presentation for us, which, as I mentioned, is going to be quite impressive, and to join us today to present it. So with that in mind, would you please join me in giving Dr. Anup a most warm welcome.
Thank you, David, for that kind words. I know that few of you know me. The problem is, these days we see only the eyes because we are covered under the nose by the mask. So if you don't realize me, this is how I look with the mask. I may not realize you or, remember you seeing your faces because again, I also have the same problem. So apologize if I don't smile to anybody. David is always there with us, so David is a key figure with us. So what I'm going to talk in the next 1 hour or maybe a bit more is about basics of myeloma. Dr. Christine Chen had given you a wonderful talk on what is new in the treatment. So I'm just going to talk about the basics of myeloma. Okay, so this is a basic presentation. I'm going to give you an overview because this is a patient support group. I've tried to make it as simple as possible, but then, I may still have a few medical terms in between. So please, if you have any problem, if you find anything difficult, please raise your hands, please stop, and then we can discuss about it. So this is the outline for my presentations. I'm going to give you a basic idea about what myeloma is, a few slides about history of how myeloma evolved as a disease and as a treatment, what are the symptoms of myeloma, how do you diagnose myeloma, basic concepts about treatment, the philosophy of how you treat because myeloma is a long treatment, supportive care. I'm going to focus on bone disease and infection, what is coming up in the future, and then if you have time, we can always have a few questions. Okay, so you should know that hematopoiesis is a term that is used for blood formation. So you have a stem cell which can give rise to any blood cell, any mature blood cell. And the stem cell can either be committed to become a myeloid stem cell or a lymphoid stem cell. And subsequently, the myeloid stem cell produces a red blood cell, which is the hemoglobin carrying cell. Some of it can become platelets. Some of it can become what is called as a myeloblast, from which the neutrophils or the granulocytes, basophils, and eosinophils are formed. The other commitment is towards the lineage called as a lymphoid stem cell, from which you have lymphoblast. And this lymphoblast can become either a B lymphocyte, a T lymphocyte, or a very unusual cell called a natural killer cell. So what happens with the B lymphocyte is, the B lymphocyte undergoes multiple phases of maturation, and the final matured B cell is what is called as a plasma cell. Now, the plasma cell is a culprit cell in myeloma. Now, as I said, plasma cell is a final product of B cell. Now, these are round to ovoid cells. If you ask a pathologist about plasma cell, they would say that plasma cell is the most beautiful cell to see under the microscope because it has got an ovoid shape, the cytoplasm is pale blue, and the nucleus is eccentrically placed at the side, which is purple in color. In a normal person, it is found only in the bone marrow. It constitutes around 2 to 3% of the bone marrow cell in a normal person. It has got immune function. The basic function of a plasma cell is to produce antibodies, and these antibodies are normally called as immunoglobulins. Now, looking about immunoglobulins, now this is the basic structure of an immunoglobulin. So, each immunoglobulin has a heavy chain, that's the blue long one. So, a pair of heavy chain, this will be identical, and on the heavy chain attached is a small light chain which is red in color. So, these immunoglobulins are protein molecules, and the main function of immunoglobulin is it acts as an immune response against, so it mediates an immune response against infections. So, the blue part of the heavy chain can be an alpha heavy chain or a gamma heavy chain, a delta heavy chain, epsilon heavy chain, or a mu heavy chain, one of these. So, one immunoglobulin will only contain either an alpha or a gamma or a delta, it can't be in combination. Now, the light chain again can be either a kappa or a lambda. You have heard this name kappa, lambda, A, D, so that's why I'm bringing this in this discussion. Now, it's very important to know that a particular plasma cell produces only one kind of immunoglobulin, which means that if this heavy chain is A and if this light chain is kappa, this plasma cell will, that specific plasma cell will produce only an immunoglobulin called as IgA kappa. And there is always a little bit of extra light chains that is produced because the light chain always has to bind to a heavy chain, and if there is no heavy chains to bind, which can happen in a normal person, light chains can be normally found in the blood, and that is for the same reason that light chains will never be zero in your blood even in a normal person. So, light chains are normally detected in the blood. So, having a little bit of light chain in the blood doesn't mean that it's abnormal. Okay, so again I said among the immunoglobulin heavy chains, 80% of the time it is the gamma heavy chain. So, you call that as an IgG, 15% is IgA, 5% is IgM, and then IgD and IgE are very rare. Now, this is what happens in a normal bone marrow. You have different kinds of plasma cells, and each plasma cell, as I said, produces a unique kind of immunoglobulin. So, these different kind of plasma cells are called as polyclonal plasma cells. These are multiple clones, and these polyclonal plasma cells or different plasma cells produce different types of antibodies which are called immunoglobulins. And then, as I said, there is always a little bit excess of light chains, and so that's the reason why light chains are normally detected in the blood. Now, what happens in myeloma is, for some reason, we don't know what's the cause of myeloma, one clone gets a survival advantage than the others, and that clone starts multiplying, suppressing the others. Because it is coming from a single clone, this is called as a monoclonal plasma cell. Mono means one, and the production of the antibodies by this monoclonal plasma cell is called as monoclonal protein, and that is what you call usually as the M protein or the M spike. So, here in the last picture I have shown you the plasma cells in different colors, just to say that there are different kind of plasma cells, but in myeloma it is a single clone, that's why I have given everything in blue color. So, it's a monoclonal plasma cell, and it starts producing just one kind of antibody which is abnormal, and this sorts of crowds and suppresses the other antibodies. Now, plasma cell neoplasms is a group of disorders which is caused by abnormal proliferation of monoclonal plasma cell, and this can be also called as monoclonal gammopathy. There is a long list of plasma cell neoplasms. You would have heard about many of this, and multiple myeloma is essentially the most common type of plasma cell neoplasm among these. Now, going to types of myeloma, I showed you the structure of immunoglobulin. It has got a heavy chain and a light chain. So sometimes the abnormal protein could be an intact immunoglobulin, which means a immunoglobulin which has both the heavy and the light chains. So that is where you call it as an intact immunoglobulin multiple myeloma. And that is, for example, if you say IgG kappa myeloma, IgG is a heavy chain, kappa is a light chain. So that patient has got an intact immunoglobulin myeloma. Sometimes the light chain production can overwhelm, and then this is the condition where the monoclonal plasma cell produces only a light chain. This is only in around 15%, and that is when you see as a light chain myeloma, which could be either a kappa or a lambda. Very rarely, in around 2 to 3% of patients, you can have either a very small amount of proteins produced which can't be detected, or the plasma cell may not produce any antibody at all, and that is called as a non-secretory myeloma. And here you don't find a monoclonal protein, you don't find a kappa or a lambda, and this is found very less in around 2 to 4% of myelomas. Again, type of myeloma, 50% will be IgG, so it can be IgG kappa or lambda. 20% can be IgA, which can be IgA kappa or lambda. Then you have M, D, and E. 15% can be, as I said, only light chain myeloma, where you have either kappa or lambda. And then around 2 to 3%, there is no light chains, or these are called as non-secretory myeloma. Now, this is a $1 million question. What causes myeloma? Nobody knows it. The exact cause is unknown, but age is the most significant risk factor because myeloma is usually seen at the 7th decade. It is more seen among the blacks than in the white race, and it is less common among the Asian race. There are some associations which have been seen, but nobody has pointed out at one of them as the most common or the significant cause of it. There are some reports about associations of exposure to pesticides, radiation, working in the leather industry, again exposure to various chemicals, benzenes, etc., etc. Now, focusing to multiple myeloma, if you look at all the cancers, it's only 1% of all cancers. It is 10% or 15% of all the blood cancers. This is the most common primary cancer affecting the bone. So you can have secondaries from other organs which affects the bone, but myeloma is the most common primary cancer affecting the bone. And if you look at the US data, the incidence is around 4 to 5 per 100,000 people. The median age, as I said, is 66, so it's usually seen in the 7th decade, and around 35 or 1/3 of patients is usually more than 75. 10% of patients are young, they are less than 50, and there are 2% of patients who can be less than 40. It's slightly more seen among men than in women. Now, this is the Canadian data which I could get from the CMRG, and so the CMRG has collected data starting from 2007. I think they have been collecting over the years, and they have a database of close to 10,000 patients, and out of which around 49% of them have undergone a transplant, 8% of them have undergone 2 transplants. I am coming to all these in the next few slides. Okay. Now, in myeloma, there is something called as precursor lesion. So, there is something that happens before myeloma, and then myeloma comes. And these are called monoclonal gammopathies, and the 3 stages of myeloma is you can have a phase called MGUS, or the monoclonal gammopathy of undetermined significance, which progresses to what is called as smoldering myeloma. And as seen in this figure, this triangle is the tumor burden. So the tumor burden slowly increases from the MGUS phase. You have smoldering myeloma, and as the tumor burden increases, it becomes multiple myeloma. So in monoclonal gammopathies, you can have, if it is a secretory myeloma, you can have an M protein, but this will be usually less than 3 grams per deciliter. In our units, it will be less than 30 grams per liter. The bone marrow will have plasma cells, which is less than 10%, but there is no end organ damage, because myeloma always causes end organ damage. I'll come to that in the next few slides. As the tumor, and then MGUS is very prevalent in the normal population, that if you go to the community and do a random survey, In people, normal people who are more than 50 years, 3 to 4% will have an M protein. So it is found normally in the population. It's not a cancerous lesion. As the age advances, as I have shown here, the prevalence increases to 5% when you are more than 70 and around 8% when you are more than 85. So some people even say this could be part of the normal aging process. We don't know. The MGUS is not a malignancy, it's a precursor lesion. And as the tumor burden increases, as the M protein starts to rise to more than 30 grams per liter, and as the bone marrow plasma cells cross to more than 10%, you get what is called a smoldering myeloma. But again, in smoldering myeloma, there is no end organ damage. So the myeloma is slowly smoldering or slowly growing. And once you start developing end organ damage, that is when you call it as a symptomatic myeloma or as a multiple myeloma. Important point to notice, all myelomas have a precursor phase, but then more than 90% of patients never know that because they are asymptomatic, and these are specific tests, and these are not tests that are done usually in a clinical, in a community level, but all precursor lesions doesn't become myeloma. So if you have an MGUS, it doesn't mean that you are going to become myeloma someday. So this is the graph which shows how does an MGUS and a smoldering myeloma progresses. So the lower one is the yellow curve is the progression of MGUS to myeloma. So if you have an MGUS, the progression to myeloma is 1% per year, which means if you have 100 MGUS today, one of them will become a myeloma in the next 1 year, and so every year the progression is 1%. The next phase, as I said, is smoldering myeloma. The progression is, in the initial first 5 years, the progression is 10%. Then it sort of plateaus to or flattens to 5% in the next 5 years, and after the first 5 years or after the first 10 years, it again becomes similar to MGUS, like 1% per year, which means that if you have a smoldering myeloma, the maximum chance of progression to myeloma is the first 5 years, then it sort of decreases in the next 5 years, but once you have crossed 10 years with smoldering myeloma, the chance of you getting myeloma is very low, which is like 1% per year. Now, is there a way to predict this? Is there a way to predict what are your chances to become a smoldering myeloma to a myeloma? There are a lot of prediction models. The easiest one to remember is called as a 20-20-20 rule, which was formulated by the Mayo Club, the Mayo Clinic, sorry. So the 20-20-20 rule means they have looked at 3 parameters. The bone marrow plasma cell should be more than 20%, M protein should be more than 20 grams per liter, and the ratio of the light chain kappa to lambda or lambda to kappa should be more than 20. So this is 20-20-20. If you don't have any of these risk factors, so 0 risk factors, you have a low risk of progression from smoldering to multiple myeloma, which is said to be 6% at 2 years. If you have any one of these risk factors, you call them as intermediate risk patients, and the risk is around 18% at the end of 2 years. But if you have 2 out of the 3 risk factors, you call them as high risk disease, and here the chance of progression is 50%. So 50% of patients by the end of 2 years with smoldering myeloma with 2 out of these 3 risk factors can become a multiple myeloma at the end of 2 years. Okay, so this is about basics of what myeloma is and the background, and then now we are going to a bit of a history. Now, history is always amazing because, if you look at the history of cancers, long back in 1600 BC, there is documented evidence of description of cancer back in the Egyptian culture. 400 BC, the Greeks started studying about cancer. They thought that cancer is an aggressive disease, and that is how the emblem of cancer was a crab. Because the same way as crabs start squeezing you, they thought that cancer is such a devastating disease. Blood cancers were described as early as 3 to 4 BC in Greece, and then this scientist called Anton Leeuwenhoek pricked his fingers, he made his microscope, and back in 1695 he saw his red blood cells. And then again, there has been a lot of reports about blood cancers which were initially called as globuli albicans as early as 1700. But the first case of myeloma was back in 1844 in a lady who was 39, and her name was Sarah Newberry, and her case was described as a lady with fatigue and bone pain who presented with multiple fractures. Now, this is a very conceptual figure of somebody who was drawn about Sarah Newberry, but then back even in those days, people know that there is a disease where you could have fatigue and multiple bone pain, and then later on this was evolved, research evolved, and then they found that this is myeloma. And then again, report starts coming up about such diseases, and then this is a patient called Thomas who has described that the pain was as if he felt something had snapped away in the chest. So what he's describing is about probably a rib fracture. And then one unique thing which some of the patients notice is when these proteins, abnormal proteins, starts getting secreted in the urine can become viscous and it can start stiffening the cloth, because the cloth can get stiffened if the urine is stained, if the cloth is stained with urine. And this is one remarkable letter which a doctor by the name William McIntyre writes to Dr. Johns, who is a very famous biochemist of those times, and he describes about this urine. He says that this urine has got high specific gravity. When I boil the urine, it becomes opaque and cloudy. When I cools it, it again becomes clear. And he's asking what it is. And later, this urine protein was given the name Benz-Johns proteins, named after this biochemist called Dr. Johns, who did research about this kind of urine. Now, this slide summarizes milestones in myeloma. This is a very crowded slide, but then, the M spike was initially called as the church spire back in 1939, and then two researchers from MSKCC, Congold and Lipari, found that there are other proteins. To commemorate them, K was named as kappa and L was named as lambda. And then back in 1958, melphalan was used in relapsed myeloma. The most amazing story is of thalidomide. Thalidomide was the first immunomodulator that was used in myeloma, and the way thalidomide was used is a serendipitous discovery. So thalidomide is known to inhibit blood vessel formation. So for any cancer to grow, you need to supply oxygen to the cancer. So there is always blood vessel formation around the cancer. Thalidomide acts by a mechanism called anti-angiogenesis, which inhibits the blood vessel formation and cuts the nutrients to the cancer. So the story of how thalidomide was used in myeloma is about this Manhattan lawyer called Beth Wormer, whose relative was a researcher who was researching on thalidomide, and tells her about this amazing potential of thalidomide, about its anti-angiogenic properties. Unfortunately, Beth's husband who was a cardiologist, had a very aggressive myeloma, who had failed multiple types of treatment, including 3 transplants. And this lady somehow wanted to try thalidomide as an option to her husband. So he sees everybody, he pleads, and particularly to Dr. Bart Barlogi at the Arkansas Medical School. And finally, Dr. Barlogi succumbs to her pressure, starts Dr. Wormer on thalidomide, and in fact he lives for a few months. And then thalidomide is started to be studied, and this revolutionized the treatment in myeloma. So this is few glimpses about milestones of myeloma, and now we go to the symptoms of myeloma. So we discussed about basics, we discussed about a few historical landmarks in myeloma treatment. Let's come to the symptoms of myeloma. So what happens in myeloma? So I said myeloma is a disease which is caused by proliferation of plasma cells. So these plasma cells are in your bone marrow. They start proliferating, they crowd the bone marrow, and then the normal production of the red cells is decreased. So when the hemoglobin producing red cells are low, you get anemia, the hemoglobin drops. The normal plasma cell produces normal polyclonal immunoglobulin. In myeloma, one type is abnormally proliferating, so the normal immunoglobulin production is decreased, so you get infections. There is this abnormal monoclonal proteins produced by the single type of an abnormal protein. This makes the blood viscous. This can deposit in kidneys, causing kidney failure, and this can also cause neuropathy because it can again have manifestations on the nervous system. Again, there is erosion of the bone which causes lytic lesions, fractures, and the bone is made of calcium, and when there is erosion of the bone, you can have the calcium in the blood going up, which is called as hypercalcemia. Now going into more detail about what happens in the bone. Now the normal bone homeostasis is maintained by two processes. One is bone formation and there is bone destruction. So both go hand in hand. Bone formation essentially happens from birth till you are growing, and then it sort of stops, and then it remains stable, and then there is what is called as age-related osteoporosis, where there is a small amount of erosion that happens. What happens in myeloma is this balance is tilted towards destruction, which is called as osteoclastic activity. So the osteoclastic activity is activated, and osteoblastic activity or the bone formation is inhibited. So the balance goes towards bone destruction. There is resorption of the bone, and then you start seeing, these are the classical punched out lesions that you can see on the X-ray of a myeloma patient. You can have lytic lesions, and then you can have pathological fractures. What are pathological fractures? You know that a certain amount of force is required to break a bone. Pathological fracture is a fracture which happens on trivial trauma. You just hit somewhere and normally you should be fine, and then your bone starts breaking. That's called as pathological fracture. And then you may have compression of the spine, collapse of the spine. You can have bone proliferation or the plasma cell deposition outside the bone marrow in another bones which are called as plasmacytoma. Oma means tumor, and then as a result of this erosion, the calcium can be high, which is called as hypercalcemia. So with all this, so myeloma, if it affects the bone, you can have bone pain, you can have fracture, you can have spinal cord compression by a vertebra which is collapsed and compressing on the spinal cord, and then you can also have nerve compression because this collapsed vertebra can compress on a nerve that arises from the spinal cord. Bone is made of calcium, so when there is erosion of the bone, all the calcium comes to the blood. What happens? You can have increased thirst, you can have increased urination. If the calcium goes beyond a limit, like 13, 14, 15, very high levels, you can have nausea, vomiting, constipation, and you can even have a brain fog if the calcium is very high. You may be obtunded, you may be always sleeping, you may be aroused back, but when we leave you again may go back to obtundation. Kidney failure, again, non-specific symptoms like nausea, vomiting, malaise, weakness. Bone marrow infiltration, as I said, can cause anemia. When the bone marrow is crowded and the normal blood production is decreased, especially if the platelet production is decreased, you can have bleeding tendencies. Decreased amount of immunoglobulins can cause recurrent infections. Pneumonia is the most important. It can kill a person with myeloma. Hyperviscosity is when the proteins are high in the blood becomes viscous. You can have shortness of breath, you can have stroke, you can have bleeding in the eyes, you can have bleeding elsewhere, and you are at a high risk of blood clots because the blood is really viscous because of the abnormal protein. Now, the most common clinical features in myeloma is called as CRAB. And CRAB is increased calcium, R for renal failure, A for anemia, and bone pain or bone lesions in 58%. So this is the prevalence of these most common clinical features that is usually seen. And then you can again have non-specific symptoms like fatigue and weakness in around 1/3 of patients, weight loss in around 24%, neuropathic symptoms, liver enlargement, spleen enlargement, lymph nodes, fever in a very small minority of patients. Now, when do you suspect myeloma? So, if you have bone pain, if you are found to have lytic lesions, if you start breaking your bone with trivial trauma, If you have an abnormal protein concentration which is called as a monoclonal protein, if you have an anemia which can't be explained by any other reason like bleeding or decreased iron or decreased vitamin B12, if your calcium is found to be high, if you have a fracture on a trivial trauma, or if you have a classical combination of anemia and renal failure, like high creatinine and low hemoglobin. So these are the instances when the doctor should suspect that this is myeloma, and as an autopilot should start evaluating for the test. So how do you diagnose myeloma? So these are symptoms, and how do you diagnose myeloma? So to diagnose myeloma, the doctor should have two things. One, I said that myeloma is a disorder of plasma cells. So he should demonstrate that there are clonal plasma cells, and he should also demonstrate that the patient has also started having the effect caused by the plasma cell. I say that because in MGUS also you have plasma cell less than 10%. In smoldering myeloma also you have plasma cell which is more than 10%, but you don't have the effect of the plasma cell. So only when you have plasma cell and the effect of plasma cell, you diagnose myeloma. And the current criteria for diagnosis of myeloma is you need to demonstrate bone marrow plasma cell more than 10% in the bone marrow, or you should demonstrate plasma cells in any other areas. I said the plasma cells can deposit as tumors in other areas outside the bone marrow, which is, and that's called as a plasmacytoma. So you can demonstrate plasma cell either in the bone marrow where you have to have it more than 10%, or you need to demonstrate outside the bone marrow where we call it as a plasmacytoma. Plus the effect of the plasma cells is given an acronym called SLIM CRAB, which is 60% of more of clonal plasma cells, light chain ratio of more than 100, MRI showing focal lytic lesions, and again the CRAB, which is calcium, high creatinine, low hemoglobin, and bone lesion. So this is called as the SLIM CRAB criteria, and this is the criteria which summarizes the effect of myeloma. But these are the investigations that is usually done. So you have a blood counts, you look at the kidney functions, the creatinine and the liver functions, the electrolytes and the LDH. These are essentially done to see what is the proliferative potential of the disease. You look at the calcium level, because I said the calcium levels can be high in myeloma. Uric acid is again an abnormal. It's a electrolyte that is produced by increased lysis of the blood cells. Then you look at the protein, the abnormal protein. So you do tests called the serum electrophoresis and the urine protein electrophoresis. Look for the Benz-Jones proteins in urine, the same protein which gave the doctor a confusing time because it started stiffening his linen. Then look at the light chains to see if the light chains are abnormal. Look at the immunofixation electrophoresis, which will tell you what type of myeloma it is. Do the bone marrow studies, do the cytogenetics in fish to see whether you have a high risk myeloma or low risk myeloma. Look at the immunoglobulin level. Do the skeletal survey by X-rays or CT or MRI or PET CT, whatever is available, whatever is funded, especially looking at the skull, the pelvic bone, the spine, long bones. Look at a test called beta-2 microglobulin, which tells you about the activity of the disease, and then if you have other lumps and bumps, do a tissue biopsy to find out if they are plasmacytomas, because these are very important in diagnosis and in telling you the outcomes. So this may not be very much interesting to you. So you can have this. So this is bone marrow picture of the plasma cells that are the bone marrow gets crowded with, and this is the electrophoresis, and this is the normal electrophoresis that you see. So the first spike is the albumin, then you have the beta-1 globulin, beta-2 globulin, beta-3 globulin, and then the gamma globulin. This is normal. So this is what is called as a polyclonal globulin. So you have multiple proteins. In myeloma, what happens is you have this spike called as the church spike or the M spike, and this M spike is because of the abnormal proteins called, and this is called as the monoclonal protein or the M spike. And this is the immunofixation gel which shows that this patient has got an IgG kappa myeloma. So X-rays, CT scans, MRI can show the lytic bone destruction. This is the shoulder bone, this is the pathological fracture, spinal cord compression. This is a plasmacytoma where the myeloma is depositing outside the bone marrow, and again you can have fractures in the pelvis. So this is a general overview of the bone involvement in myeloma. But there is always a confusion, what should be the imaging modality I should use? Should I use X-ray, should I use CT, should I use PET-CT, should I use MRI? Now X-rays require around 75% of bone loss to show something upon the film. So X-rays will be the least preferred modality for anybody to find a bone lesion in myeloma. CT scans, especially the whole body low-dose CTs, offer high superior sensitivity, and this can detect 25 to 50% of patients who were negative on X-rays. So CT has got a higher sensitivity. The additional advantage of a PET-CT is PET-CT will also show you the metabolic activity. So it will tell you there is a lesion, and it will also tell you how active the lesion is. So there is a value called SUV if you have looked at your PET-CT report, and that tells you about the activity of your cancer. And then if you are looking at infiltration of the bone marrow, MRI should be better. So X-rays definitely not the best, definitely not the best. So the least could be either a whole body CT, the best would be a PET-CT, but then it also can vary depending upon availability, funding, etc., etc. So there is something called stratification. So any disease in the world, you will have a standard risk disease where majority of the patients do well, they go on for many years, and then there will always be a minority where the disease is biologically very, very aggressive, and there the treatment options are very limited, and the patient can have complications. So this stratification in myeloma is based on a few parameters. The first is the genetics of the disease. So this is not the genetics of the family. So when I say genetics of the disease, it doesn't mean that myeloma is a genetic disease. This is the genetics of the cancer. Every cancer comes with a genetic signature. So, and this genetic signature in myeloma can be assessed by a test called FISH, which is done on the bone marrow. And the more recent test is you do the gene panel or the DNA sequencing. This is mostly for studies where they look at the genetics of the disease and say whether you are a standard risk or a high risk. The tumor burden is by the ISS and the RISS stage. If the myeloma comes out of the bone marrow, when you call it as extramedullary, that's a bad sign. So that's a sign of a high risk myeloma. Sometimes the plasma cells can again spill over the bone marrow, and you start seeing the plasma cells in the blood. That is called as plasma cell leukemia. Again, that's not a good sign. And again, involvement of rare organs like brain, the central nervous system, multiple soft tissues like liver, lung, etc. Which again, so these are all the features of a high risk myeloma. I talked about high risk cytogenetics. So many of you would have read your FISH report, and then it's very difficult to make out what it is if you don't. And you are not supposed to be knowing everything. So, but then just for information that the high risk cytogenetic abnormalities that is usually seen in myeloma is the deletion of a chromosome short arm called as deletion 17p, biallelic deletion of a gene called TP53, and then there is translocation between the chromosome 414. So this is too much of a medical information for you, so I'm not discussing it, I'm just leaving it as a slide without much discussion. But what's the natural history of myeloma? So how does a myeloma behave? So when you start the disease, I said all patients would have this phase called MGOS or smoldering myeloma, where the myeloma slowly progresses. You don't treat it, and at some point the myeloma starts affecting your organs, and that is what is called as active myeloma or multiple myeloma, and that is when you start giving the patient some treatment. So the myeloma responds, and then the patient goes to a plateau phase, and invariably after some time the myeloma relapses, and then you start the second line of treatment. Again it goes to a plateau phase, again it relapses, start the third line. So this is a natural history of myeloma. So The classical description of myeloma is a disease which can't be cured, which can be controlled, and the main aim of treating myeloma is to increase this plateau phase or the remission phase as long as possible by the continuous treatment. So the main aim is to increase this disease-free period to as much as possible. And we have excellent drugs that are available for treatment of myeloma, starting from melphalan, which came up in 1958. This is the year of FDA approvals of these drugs in myeloma. So 1958 was melphalan, then after around 4 years, prednisolone, which is a steroid. Then transplant came up in around 1983. What really revolutionized the treatment has been the early 2000s when Velcade or the bortezomib, the immunomodulators and the other medications came up, and that has really revolutionized the treatment of myeloma. And now you can see that almost like every year you are seeing 1 or 2 drugs getting approved. For example, if you see 2015, there were at least 4 or 5 drugs that were approved. And now 2022 we saw cilta-cel, teclistamab, and now talquetamab is approved. So newer drugs are coming up in myeloma. So this is the classification of drugs. So you have this group of drugs called antibodies or monoclonal antibodies. Daratumumab or Darzalex is the classical example. Then you have isatuximab, elotuzumab, and belantamab. Alkylating agents are not used much now. Mostly the melphalan that is used for transplant and cyclophosphamide as part of your Cybody treatment. There is the other group of drugs called proteasome inhibitors, which has Velcade, Ninlaro or the ixazomib, and the Kyprolis or carfilzomib. Then steroids, immunomodulators, thalidomide is not used anymore, lenalidomide and pomalidomide, and then you have the novel agents, which is venetoclax, selinexor, CAR T cells, and the other bispecific agents. Now, in myeloma, the treatment is always given in combination. So you take 2 drugs, 2 classes of drugs. This could be an antibody with a proteasome inhibitor, antibody with an immunomodulator. This is given along with steroids. So this is the broad classification of the myeloma drugs. Now next question is, when do you start treating patients? So we touched upon MGUS, smoldering myeloma, and myeloma. So MGUS is when the disease is very indolent, it's not a cancer, so don't treat them. See them every 6 months, do the blood work, look at their M protein, look at their light chains, but don't treat them. The next phase is smoldering myeloma. Again, they need close follow-up every 3 months. There are some clinical trials which have looked at treating smoldering myeloma, but as standard of care outside clinical trials, smoldering myeloma patients need not be treated. They need to be on close follow-up every 3 months. But once you start seeing the effect of myeloma, the effect of the abnormal protein, like the crab and the slim crab, that is when you call it as myeloma, and then there is no question, don't wait, start treatment at the earliest. Now, how do you treat myeloma? When you see a patient, the first decision that you need to make is this patient eligible for transplant? Because the treatment paradigm is different for transplant eligible patients and transplant ineligible patients. Now the next question is, how do you define eligibility for transplant? Is it age? Is it fitness? So age is always a moving cutoff. 20 years back, 65 years was considered as the transplant age. Then it became 70. Now people started considering transplant for more than 70. So it's mostly the physiological age that is more important than the number. So for example, if you are 72 and if you are fit without any illness, he should be transplanted than a 67-year-old man who has cardiac failure and who is on the bed. So it is more about the physiology, the physiological age rather than the number. So age is always a moving cutoff. So the age along with the physical fitness is what is more important in deciding whether you need to have a transplant or not. And myeloma treatment is a continuous treatment. Now this is the broad paradigm of treatment for myeloma. So you diagnose myeloma. If you are eligible for transplant, you give the chemotherapy called as induction chemotherapy, usually around 4 to 6 cycles, then do a transplant and then continue the maintenance with a pill called lenalidomide. If you are not eligible for transplant, there is no transplant, you just give a continuous treatment until the disease progresses. And then the tumor burden can decrease along the treatment, and then at some point the myeloma can relapse. So what do you do with transplant eligible patients? So this is, as I said, you have an induction treatment, transplant and maintenance. And the most common induction treatment that are usually given this part of the world is RVD, which is a combination of Revlimid or lenalidomide, Velcade or bortezomib, and D is dexamethasone, which is a steroid. Cyborg is a combination of cyclophosphamide, bortezomib, and dexamethasone. And what is now becoming new is the addition of daratumumab to RVD, because there is a lot of data saying the addition of daratumumab has significantly improved the outcomes in patients, but unfortunately this has not been approved for patients in Canada, for patients who are transplant eligible. Transplant is by a single drug called melphalan, so you get the injection melphalan and 1 or 2 days later you get the stem cells and then wait for your blood counts to recover. And after transplant you do what is called as maintenance, where you will get a pill, either lenalidomide or ixazomib, and this is continued till the myeloma relapses. And a standard risk myeloma without any of the high risk features, the median time till the myeloma relapses will be around 4 years. What happens if you have a high risk disease? There is something called as a tandem transplant, where you have a high risk disease, where instead of one transplant you do 2 transplants back to back at a gap of 3 months. Melphalan is the chemo that's used. So you do a transplant, wait for recovery, 3 months later do another transplant. And again, maintenance, you may give a dual maintenance with 2 drugs. You can combine lenalidomide and ixazomib. The reason is a high risk patient, the chance of relapse is very high, the chance of him relapsing is very early. So we are trying to intensify treatment as much as possible by 2 transplants and 2 drugs as maintenance. Now, transplant ineligible patients who are elderly and unfit, you give a continuous treatment. This could be daratumumab with lenalidomide dexamethasone, or lenalidomide with Velcade and dexamethasone. There is a therapy called RVD Light, which is a dose adjusted RVD for frail patients. Again, if you are very frail, you can use a treatment combination of Revlimid and dexamethasone, and then there is also a combination of ixazomib, that is Ninlaro, with Revlimid and dexamethasone, which is a combination of these 3, and all treatment can be taken as a pill. Now, how do you assess response? You have heard this term partial response, VGPR, complete response, when you go to your doctor. So you look at a protein, you know that there is an abnormal M protein, and that serves as a surrogate marker for your response. So if the M protein decreases by 50%, you call it as a partial response. If the M protein decreases by 90%, you call it as a very good partial response, or a VGPR. If the M protein completely disappears, you call it as a complete response. Now, I told about a very unique situation where you may not have an M protein or a light chain, which is called as a non-secretory myeloma. There, the only way to track your disease is by doing a bone marrow. So, and the bone marrow has to have good amount of plasma cells to show that you have myeloma. So there, this response assessment is not well defined, and the same is the case when you have a light chain myeloma, where you look at the difference in the light chain. I am coming to that in the next few slides. So let us look at this example. This patient had an M spike of 50 grams at diagnosis. After the end of 2 cycles, his 50 gram M spike reduced to 20. So it is reduced by more than 50, but it is not more than 90. So what do you call this response as? Partial response, yes. A 50% reduction is partial response. This patient takes 2 more cycles of chemo, and then now the 50 becomes 3. So you always look from the baseline. 50 becomes 3, and now there is a more than 90% reduction. So what is it now? It's a very good partial response. It's a VGPR. So 50% or more is partial response, 90% or more is VGPR. If the M protein completely disappears, we call it as a complete response, and then that's how you assess response. The next slide is, why such a complicated treatment in myeloma? Why is this happening? Other cancers, you either continue treatment, do a transplant and stop. Here it is chemo, transplant, and then maintenance. Now this is one example which I tell many of my patients. So this is a tree, and consider that this is what we see outside. This is myeloma that we see. Now you should also understand that tree has a root down. This is what we see in the blood and the bone marrow. So we see M spike in the blood, we see the light chains in the blood, and we see the plasma cells in bone marrow. So when you treat and when you say that the M spike, the light chains, and the plasma cells have disappeared, it doesn't mean that this part is gone. So that is the area that is not detected by conventional methods, and that is the reason why myeloma is a continuous treatment and it is very complicated. As you treat more, you are trying to pull out the roots. So the classical philosophy is the induction decreases the bulk. So you decrease the disease as much as possible. The M spike decreases, the light chain decreases, the bone marrow decreases. Transplant deepens the response. So you have cut down the tree here, but if you leave it there, in a few, just a matter of time that the tree is going to grow up. The transplant is going to deepen the response to as much as possible, and then you have the post-transplant strategy called maintenance, which will further deepen the response or will try to maintain the response that is already achieved. So this is what happens. So you control the disease, it comes back early. If you control it more, it comes back but a bit late. A bit more, it comes back but very late. So the deeper the response is, or the more deeper you go and pull out the roots, the chance of the disease will come back, but then the disease is going to come back very late. And there is also a group of patients who are like functionally cured, because there you have gone so deep and pulled out even the last twig of root that there is nothing left there for the disease to relapse. And this is a group of patients who go for 15, 20, 25 years after treatment. And then I told about the partial response, complete response, stringent response, etc. Now you have to understand that here we are enumerating the plasma cells out of 100 cells. So you count 100 cells and say how many of them are plasma cells. It's a very crude method. But when you go deeper down, you are looking at 1,000,000 cells and then counting how many of them are plasma cells by sophisticated methods called flow cytometry and molecular methods, and this is the concept of MRD. So MRD, or minimal residual disease, is the lowest residual disease that you can attain. If you attain MRD, it is very good. The more deeper you attain, the better, because you are going to have a longer remission, and you will have a few patients where the MRD becomes undetectable and they may take many years to relapse, or they may not relapse at all. Now what happens when you have a relapse? So as I said, invariably all patients would relapse at some point of time, and in a standard risk patient this relapse happens after a median of 4 years. It can be at 1 to 2 years if the patient has got high risk disease. And what is very unique about myeloma is you have given a treatment for myeloma. When the myeloma relapses, this myeloma has already become resistant to whatever treatment you have given. So then you use a completely different type of drugs, and then you use newer drug class or a next generation from the earlier drug class. And then comes the philosophy of how do we treat patients at relapse. So you always look at what all drugs or medications this patient has received in the beginning. Because if the patient has already received lenalidomide at diagnosis, there is no point in giving it again. Look at the age of the patient, look at the frailty of the patient, look at the other comorbidities. We don't want to treat a patient with a drug which can cause more trouble than the cancer. So look at these points. Look at the toxicity. Some of these drugs are toxic. So if you have already received a group of drug which causes neuropathy, Don't give any other drug which again has the same symptoms. So look at the toxicity. Once a myeloma relapses, we are dealing with a population which is 70, 80. Look at the patient preferences, goals of care, and then as much as possible enroll the patient to clinical trial. So this is again a broad paradigm of how you treat patients when they have the first relapse, second relapse, and further relapses. At first relapse, it's a combination using this monoclonal antibody called daratumumab or ixatuximab. At second relapse, it is usually carfilzomib, which is a second generation bortezomib, or pomalidomide, which is like the second generation lenalidomide. And then at further relapses, you go for selinexor, venetoclax, CAR T-cell therapy, and bispecific antibody. But at each relapse, always, if eligible, always look for the option of a clinical trial, because clinical trials offer the better treatment compared to standard of care. Now one slide about.
Yes, a question if I may. Do you find that with modern treatments, the toxicity is less?
Yes. So I'm coming to that point here. So the side effects of the medications. So I have only taken the medications that are used commonly. If you look at daratumumab, the side effects are usually the infusion related side effects. At the time of the infusion, you can have fever, you can have allergic reactions, but otherwise there is no other alarming side effects like lenalidomide, which can cause a skin rash, gastrointestinal toxicity, or low blood counts. Daratumumab is pretty safe. Velcade or bortezomib can cause neuropathy, gastrointestinal symptoms like diarrhea, low platelets, and very rarely you can have infections in the eye called as dye. Cyclophosphamide, which is used as part of Cybody, can cause low blood counts. Dexamethasone, which is part of all myeloma treatment, and many of you would know that you can have sleepless nights, it can increase your mood, appetite, and weight. Long-term use can cause diabetes, high blood pressure, cataract, etc. Pomalidomide can again cause skin side effects and low blood counts. Carfilzomib or the next generation bortezomib can be very risky in patients who have cardiac disease. You can have high blood pressure, cardiac failure, and a very unique side effect in the kidney called as TTP. And then there is another drug called selinexor, which can be very distressing. It can cause severe nausea, vomiting, severe fatigue, and low platelets. So as science is advancing, we are seeing that these classical side effects are becoming less and less. With the new treatment, it's a completely different kinds of side effect depending upon what mechanism of action these drugs have. And we have a lot of algorithms where the dose of the drug can be modified based on the patient's age and frailty. And as doctors, we will always be looking at the patient's age, frailty, and the other comorbidities, and then giving you the optimal drugs. Like if you have a peripheral neuropathy, almost always we avoid bortezomib. We can consider carfilzomib and ixazomib. If the patient has cardiac failure, we avoid carfilzomib. If there is kidney trouble or renal insufficiency, lenalidomide has to be used very carefully. And then lenalidomide and pomalidomide is known to cause skin rashes, and if you have had a severe allergic skin rash once, this class of drugs has to be completely avoided. The next phase is about supportive care in myeloma, and I am focusing on two topics, bone and infections. So along with the treatment for myeloma with the treatment regimen, you also should address the patient's pain by giving medications for pain, the Tylenol, morphine, etc. Radiation can be a good option if you have pain because of a fracture, because radiation can decrease the swelling around the fracture, and radiation also is known to have some cytotoxic effect. If you have a fracture and if your orthopedic surgeon advises a surgical stabilization, go for it. There are also augmentation procedures for the spine, which I am coming in the next slide. And then for the bone protection and the high calcium, you can use bisphosphonates or Zometa, which is an infusion. There's another injection called denosumab, and the patient always has to be on vitamin D and calcium supplements when he is on myeloma treatment. What about vertebral fractures? Now, these are the effects of vertebral fracture. If you have a compressed vertebra, the pain is terrible. You get to have a bent posture. You have loss of height because one vertebra has collapsed, and one collapsed vertebra in the background of a weak vertebra is a risk factor for further subsequent fractures. And this actually reduces the quality of life, and you get a lot of emotional disturbance. You are walking without any pain, you are running around, and now suddenly you are bent, your height is reduced, you have a lot of pain, and this can cause a lot of emotional disturbance. So what are the options? There are two vertebral augmentation procedures that can be done. One is called as a vertebroplasty, and the other one is called as a balloon kyphoplasty. So essentially, if you look at this picture, this patient has got a compressed or a fractured vertebra in between, and what happens in vertebroplasty is an injection is given there. This injection is a bone cement, and the chemical is called polymethyl methacrylate, which sorts of increases the height of the vertebrae, which sort of strengthens the vertebrae and increases the height. The other procedure called balloon kyphoplasty is, if the compression is so much, you can put the needle, insert a balloon through the needle, inflate the balloon. So the inflation of the balloon causes the vertebral height to increase. Then take off the balloon, and into the area that is created by the inflation of the balloon, you can fill in the bone cement, and this again regains the strength, increases the height, and dramatically decreases the pain, and this is called as balloon kyphoplasty. Next is about infections in myeloma. So the various causes of infections in myeloma is the T cells can be dysfunctional, the normal immunoglobulins are less, the neutrophil count can be low because of myeloma and also because of the drugs. Patients who are old and frail, who are on the bed, the risk of infection is high. Increasing age, frailty, kidney dysfunction, all these are risk factors for infection. So you give prophylaxis, you give prophylactic antibiotics, you give anti-shingles tablet called acyclovir or valacyclovir when you are on myeloma treatment. You give a tablet called Septra or a syrup called atovaquone. Now this is given specifically to avoid an infection called PJP or a pneumocystis pneumonia. And in patients who have very severely reduced immunoglobulin level, you can give IV immunoglobulin or subcutaneous immunoglobulin, which will increase the immunoglobulin level and decrease the risk of infections. Now what is new in myeloma? So this is the plasma cell. So earlier treatment was all chemotherapy. So now this is the era of immunotherapy. Now this is the plasma cell, and you have a lot of receptors on the plasma cell. There is receptors called BCMA, there is receptors called GPRC5D, FCRH5, CD38, etc. So the immunotherapy is looking at targeting the receptors which directly kills the myeloma cell without causing collateral damage. So agents like belantamab, elranatamab, teclistamab, these target this receptor called BCMA on the plasma cell. Then there is the latest one called talquetamab, which targets the GPRC5D on the plasma cell. Cevostamab targets another called FCRH5. So this is the era of immunotherapy where you are specifically looking at a receptor and trying to kill the plasma cell. CAR T cell therapy also works in the same way. So essentially CAR T cell therapy means you are taking your own T cells, you are sending it to an external facility, you are enhancing them and making them as super soldiers and then giving back to you, and these CAR T cells are circulating in the body controlling the disease. So the phases of CAR T cell is the patient undergoes what is called as pheresis. Now this is like the stem cell collection that patients undergo before a transplant, but here the T cells are separated. In stem cell transplant the stem cells are collected, but here through a different mechanism the T cells are collected. The T cells are pre-activated and sent to an external facility where they are transduced with lentivirus, where the cells are augmented and enhanced, they are reprogrammed into this super soldiers called as CAR-T. They are expanded and they come as products. And this cryopreserved product is shipped back to the hospital, which is infused to the patient, and this starts circulating in the blood and starts controlling the disease. And we have two excellent products available. One is called as the Idacel or the idacaptogene, and the latest one is called Cilta-Cel or Ciltacaptogene. And this is the response curve of the Cilta-Cel, and you can see that these patients have shown a flat curve, which is even after 3 years, there are at least 50 to 60% of patients where the myeloma has completely disappeared, and this patients needs long-term follow-up. The new drugs is called as bispecific antibodies, where you have a drug with two arms. So this is a drug with two arms. One arm binds to the T cell, the other arm binds to the plasma cell. What essentially happens is this bispecific antibody brings the T cell close to the plasma cell, so it engages the T cell and the plasma cell, and this T cell starts killing the plasma cell. And here comes the teclistamab, elranatamab, cevostamab and talquetamab. So these two class of drugs, the bispecific antibodies and CAR T cell therapy, are really going to revolutionize the treatment of myeloma. This table is again very busy, but then this is preliminary data of teclistamab, elranatamab, talquetamab and cevostamab. Now these are patients who have failed at least 13 lines of treatment, at least 5 but up to 13 lines of treatment, and if you see, the time to first response is 1 month. So as early as 1 month in a high risk multiply relapsed refractory patients, these new class of drugs are showing response. Now I am coming to the close of my presentation. So this shows the evolution of treatment. 1950s there was steroids, then there was nothing till 62 when melphalan came, and till around 2000 it was a combination of steroid, melphalan as tablets, etc. And then something happened here when Velcade, lenalidomide, carfilzomib and pomalidomide came. So what has happened after that is this fantastic improvement in the survival. Now this is a data in mid 2010s, which is at least 8 or 9 years back, and there the 5-year survival of myeloma was 66, and many drugs have come after that, and I am sure that this curve is only going to go up. So the survival with years is improving in myeloma. We have new novel drugs, we have better supportive care. As doctors, we have better understanding of the biology of the disease. So myeloma is now considered as a chronic disease. You live with myeloma with good quality of life. And we are brightly looking towards this bright future. So this was something Dr. Stewart had tweeted on February 24th when Cilta-Cel was approved by Health Canada, but we are still awaiting its funding, because once Cilta-Cel comes, this will be a great treatment option for patients with relapsed myeloma. I will close here. I will be happy to answer questions. Thank you so much.
And you know something that you was talking about this. I'm on the ER treatments for about 4 years. There's some discussion, I hope there is, about the introduction of the dexamethasone. Any thought on have you considered reducing the amount of dexamethasone on maintenance treatment?
Okay, so again, sorry? Okay, yeah, so the question here was, Bob is on DRD for the last 4 years after your third transplant, and then there are some it's a concern or a point that is raised whether he should reduce the dose of dexamethasone or the Revlimid.
A caveat, I want a very low dose of 8 milligrams.
Dexamethasone, okay. And the daratumumab is once a month.
Yes, one subject.
Okay. So, it all depends upon, if you look at is somebody talking? Sorry. Hello? Okay. So, if you look at the DRD protocol or the DRD regimen, after around 8 months, the daratumumab becomes once a month, the lenalidomide continues, and the dexamethasone again becomes once a month. So, first thing is, what is the reason why you are on a weekly dexamethasone? Because that's not the usual schedule. Sometimes some people can become dependent on the steroids. For example, if you take steroids for a long time and when you withdraw it, they can have withdrawal symptoms. Usually, steroids are not given on a weekly basis for a long time. It can be reduced, but then if the disease is under control, we can reduce. And the other consideration for decreasing any drug would be, are you having any side effects of the drug? For example, when you are on steroids for a long time, you can have osteoporosis because of steroids. You can have cataract because of steroids, high blood pressure, uncontrolled diabetes because of steroids. So these are the things that you should look. But steroids can be safely reduced to once a week because in the DRD, daratumumab is the most potent myeloma drug. So as long as you continue the daratumumab, it is safe for the steroids to be reduced to once a month because you are on 4 years. Yeah, so I don't think that's a problem. The same thing with lenalidomide. Len is usually given at around 10 to 15 or maybe 25, but as you take it for a long time, the blood count starts decreasing. You may have to be given supports like Rastafil for the blood count. So at that point, if the myeloma is under control, we can consider decreasing the dose of lenalidomide. So it's a trade-off between how effective or how well the disease is controlled, and on the other side, how much toxicity you are having with this culprit medication. So with DARA going on once a month and with the disease under excellent control, steroids can be safely reduced to once a month, unless there are any compelling reasons why it is kept once a week. Yeah.
Question from the chat. How do you know when someone is cured?
Okay, that's an excellent question. That's a $1 million question. I don't have a correct answer for it. Now, we don't know whether myeloma, we don't know about, as of now, myeloma is a disease which is considered as incurable. And MRD testing is one test which will tell you, with whatever limitations that we have, that the disease is not detectable. But 1 point MRD doesn't mean that you are cured, because it could be there and it could be coming up. So there is something called a sustained MRD negativity, where you repeat MRD 6 monthly, and then if you have a set of MRD which is negative, you know that the MRD is negative, the chance of the disease coming back is less. Now, how do I know that the myeloma is cured? This patient, when the myeloma is cured, has to die of some other disease. Then I would say this patient was cured of myeloma and he died of something else. As long as the patient is alive, you keep doing MRD, and it's bone marrow MRD, right? I mean, it's not always, a good experience to have a bone marrow every 3 months or every 6 months. And MRD is a very costly test. So the simple answer is, if your myeloma is under control and when you die of something else, you can say that this patient was cured of myeloma and he died of something else. But as of now, I don't have any test which would say that the patient is cured of myeloma.
Generally, how do treatments for myeloma compare in Canada to other countries like the United States, in Western Europe, in Asia, in India?
Okay, so I'll start with Canada. Now, Canada has an excellent public funded health system, which was very amazing, which was, like a surprise for me. Because back in India, there is no concept of public funding, you need to pay from pockets. So, I used more daratumumabs here in 1 month than my 9-year practice in India. Because here Dara was like given for any patient at first relapse. And in India, 1 dose of daratumumab is equal to 4,500 Canadian dollars. And when you ask the patient to take it weekly for the first 8 weeks, a common man can't get it. Here you have access to it. Now here again the problem is approval and funding. Now for myeloma, I think the approved drug is Cybody, but then RVD is known to be better than Cybody, but then you get it through compassionate access, which is available very easily in US because there we have a mix of a public funding and a private funding system where you can access it through insurance. So I would say it has to be a mixture of both. The public funding has got its problem in the sense everybody gets a minimum standard, but there may be treatments better than that. The time delay for approval and funding, many patients may get denied, and it may come as a delayed thing. Europe, I am not sure, but then I think approvals happen a bit more faster in Europe because teclistamab was approved back in September or November. So Europe, I am not sure, but looking at these two, this is what I feel. So you have a better system, but then it needs a more, it is taking time, and that's not in our hands. This is all, all provincial and federal people are involved in this, yeah.
Another question regarding COVID vaccines. For somebody who's done all 4 of the regular vaccines plus the 2 boosters, when should they get their next? In other words, the 7th vaccination.
Okay.
Do they do it now or wait till the fall?
So among the myeloma drugs that I showed you, the drug called the monoclonal antibodies or daratumumab, that is the one which causes significant amount of immunodeficiency in the body. So if you are on daratumumab, you are still immunodeficient. So that group of patients ideally should get their COVID boosters every 6 months. The other group, there is no much studies because finally a vaccination works only if the body produces an antibody against it. Now you have a monoclonal antibody which is suppressing the plasma cell. Now suppressing plasma cells to a limit is also suppressing the myeloma, but then the normal plasma cells may also be suppressed, so the immunity may not be that good. So it's a blunted immunity. So the response may be less, and even if you have a response, it can wane down within a few months. So if you are on daratumumab, if you are on bispecific antibodies like teclistamab, if you are on post-CAR T-cell patients, we would say every 6 months booster after your first, the routine schedule of vaccinations. Because this is elderly patients, multiple treatment lines, they're immunodeficient because of disease and the treatment. So if you have completed your first set of the regular vaccines, I think once in 6 months would be a good choice.
Whereas other patients, it's not as urgent?
It also depends upon other factors like your age and your kidney. If you are on dialysis, they are again more immunodeficient. But if you are at 40 or 50s with myeloma who are stable on pills, that's not very urgent. But if you are on a monoclonal antibody, a T-cell directed therapy, 65, 70 plus, have renal failure, on dialysis, this will be the highest risk patients who will need it every 6 months. But then COVID is a new illness. The knowledge bank is widening every day. So we still don't know when we can stop vaccinations. We don't know that. Yeah, but to be on the safer side, I think this high risk, at risk patient should be on the booster every 6 months.
One of the first things I did when I got diagnosed was to look at race-based information, and it was coming from the US. So they were saying that as black men, in the US, there is a weaker response rate and a lower survival rate. Is there any sort of documentation or any tracking of that in Canada? Because I know in the US there'd be contributing factors regarding socioeconomic and general racism within the medical community that may impact how people are treated and what type of treatment they get. So are we doing any tracking of that in Canada? by race and gender?
Okay, the question is that there is a high prevalence of myeloma and the response of myeloma is less among the black race compared to the white race. If there is any tracking of patients in Canada and if there are any studies underway to look at this. Personally, I am not sure about it. I can raise this question with the CMRG and I can get back to you because there is a database and I am sure they should be documenting this and they should be tracking this. But if you look at this racial difference, there is documented data from the US that myeloma, especially the precursor lesions like MGUS and small ring myeloma, can run in a few families. This is based on a large population database done by the Mayo Clinic. And then there is also many studies which have shown that the predisposition for the black race is higher when it comes to myeloma and that response is slightly less. But in Canada, I'm not sure about it. I can check this with the CMRG. I'm sure there should be a database and there should be some data. But then what is very important is to get a mature data, it takes many years, You need this group to be followed up for many, many, many years till you come at a conclusion that there is some difference. So there may be a data that's maturing, but I don't know about.
I had to stop looking at the American sites because it was too aggressive.
There is in fact a study going on. I can't remember the name of the study by an American group was specifically looking at this population, especially if you have a family history. And I think they are tracking even normal people, normal members of the family. They are collecting the blood. I can't remember the name, but there is a study going on. Yeah. But in Canada, I'm not sure.
Another a question here in the chat. Person with low platelets on lenalidomide. Are there any standards or guidelines on whether to reduce the dose or the duration of lenalidomide with low platelets?
So, no standard guidelines. It is mostly based on experience of the doctor and also what level you consider as safe. Low platelets, 80 can be low, 8 can be low. So, what is a safe platelet? And the most important thing is when you see low platelets for the first time, always the first culprit is a disease, is a drug. So when you withhold the drug, is the platelets coming up, then you know that this is a drug. And then you sort of decrease the dose. You can either decrease the dose and see, or you can decrease the duration of the drug and give a more time for a drug holiday. Like you can give it for 3 weeks on and 1 week off, or you can give for 3 weeks on and 2 weeks off. So you can reduce the dose, you can reduce the duration. But despite reducing the dose and duration, if there is still significant low platelet, then you need to evaluate this patient because sometimes there can be a clinical entity called myelodysplasia and lenalidomide on a long-term use can cause myelodysplasia, especially if it is after a stem cell transplant. So in that setting, if the low platelet is persisting to be severe despite holding lenalidomide, this patient has to undergo detailed evaluation with a bone marrow test to find out the cause. Is the bone marrow having enough reserve to produce it? If the bone marrow having dysplasia or some other reasons. So no guidelines for it. You can reduce the dose by one level. Say for example, if somebody is on 10, you may reduce it to 10 and 5 on alternate day or even 5, and then you can see how the platelet count responds. But there are no definite guidelines.
Hard to make a choice, but you mentioned that we should have vitamin D, and I was wondering what recommendations you would have as to the frequency of the levels of vitamin D, so you know how to adjust the vitamin D doses.
You mean the blood test to see?
Yes.
Okay. So calcium and vitamin D has to be supplemented because this enhances the bone. Calcium is anyway done on all visits. That's a part of the routine visit for any patient with myeloma because increase in calcium could be a sign that the myeloma is relapsing. Vitamin D you always should have a baseline to know what it is. And if it is very low, I think within around 6 to 8 weeks you should repeat and see whether it has come back to normal, because that's a good time to see whether it has come back to normal. And once it has come back to normal, I think it is just once in 6 months it will be fine. Yeah, but it is very low to start with. The first test has to be at least 6 to 8 weeks after you start to make sure that you are on the right track, whether you need to adjust the dose. And then once it is stable or nearing normal, I think it can be once in 3 months or once in 6 months. Yeah.
So we have time for one more question. Anybody?
Well, I'd like to ask a question with regard to the upcoming flu season and the RSV variant. The flu season and the RSV variant. What kind of precautions do you recommend for family members and also for, the patient? Right now in my family, we're all masking wherever we go. And at what point, is it safe for the family, aside from the patient, not to mask?
Oh God, that's a tough question for me. For me, all COVID viruses are bad. It doesn't. The question was the new variants coming up for COVID. What should be the precautionary measures now? Should we go back to full masking at home? Yeah, that's a broad question. So, I'm not an infectious disease specialist and we don't know much about this variant, but anyway, all COVID viruses are bad. We have had very bad experiences with COVID causing a lot of issues with myeloma patients. I would say stick on to the precautions. At home, I don't know, it's a personal call whether you have to wear a mask, but when you go out in the public, especially to very crowded places, wear a mask. That has decreased a lot of COVID infections, especially severity. Stick on to vaccinations. That's all I can say. I'm sorry that I disappointed you with this answer.
No, it's perfect answer. We want to be careful, but we're being told that we're overdoing it by some people. So I want to make sure that, family members who go to work in public areas are continuing to wear masks. We don't wear masks in the house, but if we do go out in public areas as family members, we also mask.
After a long time, UHN has allowed us to take off our mask in the office. Only at the office. The moment you step into the hospital, we are supposed to wear a mask. So, yeah, we are also getting angry with this mask going on for many years. Yeah.
I don't mind it, to be honest. I'm fine with it. It's more to respect other people's too, but just to be safe, I'd rather be safe than sorry, because it's also the flu. It's also the other variant, the RSV, I think it's called. So just a common cold. I know that with my husband, he ended up getting sick. So we want, and everyone's wearing masks. So we just want to ensure that.
I would say obviously if somebody in the family, even if you are not a patient, has got any upper respiratory infection, coughs or throat or fever, they should wear a mask, especially if you have a patient at home who is on such, immunocompromising treatment. Otherwise, there is no hard and fast rule. And it's hard to see your parents and friends and family with masks at home. It's hard.
Yes. Well, thank you very much.
Yeah.
Thank you for answering our many questions.
Yes, this is a tremendous discussion and presentation, and we could go on for quite some time further, but really we do need to vacate the room here. So a fabulous presentation. The highlight slide for me was the one showing the survival increase, and it was just increasing and getting higher and higher. And as you say, the latest data isn't in yet. It won't be in for a while, but the situation is getting brighter all the time.
Absolutely.
So Bob here has a few words of thanks.
Thanks to Dave. Just very quickly want to add to what Dave said is one word I got from this presentation today is hope. And being a long-term patient, coming into my 18th year. I want the new patients in the group to remember that. And we have come so far, and most of the drugs that I'm on now weren't even available to me in 2006. I even go back to thalidomide. So thank you very much for your presentation today. The other old saying is you learn something new every day, and I certainly did. And thank you for taking some time, and we know your time is precious. You don't get much time off. Thank you for spending it with us today and away from your family. The time you took to arrange for your slides and the questions that we had today were very well received. So on behalf of our group, we would like to present you a little gift, a modest gift of Canadiana pottery by Gabriella Kaufman. And thank you again for all of you've do for myeloma patients. Thank you for doing what you can for myeloma patients and, of course, the caregivers. So thanks again.
I would make a comment about this group. You know, when you are a patient with a disease, when you're a new patient, there will be a lot of questions which you would want to ask, but then because of time constraints, because of the fear of asking, because of some inhibitions, you may not ask the doctors. But this is the place to get the answers. You have people who have gone through this, you know, this is an ordeal. I would say myeloma is a disease which affects a family. It's not just one person, the support staff, the support person, so the family is affected. So this is the best place to come and get those sorted out. And you have people who have conquered this disease, you know, who are at the epitome of success. So, and there is no place like this where you can have your all questions answered. I'm very happy, privileged and proud to be part of this group. Thank you so much, David, for inviting me. And thank you so much for patient listening and fantastic questions.